This talk is about Lisfranc injuries. These are the learning objectives for the talk. So we'll begin by talking a little bit about some relevant foot biomechanics and anatomy that I think are critical to understand the implications of Lisfranc injury. We'll talk about the key radiographic features that you can evaluate in order to diagnose and treat Lisfranc injuries. We'll talk about the diagnostic algorithm for the more subtle injury patterns, and then we'll talk about the surgical techniques to treat these injuries, both provisional and definitive techniques of management. So just taking a kind of 30,000 foot view of the foot, just think it's really important to understand the basic biomechanics. The foot acts a lot like a tripod, where you have the first metatarsal head, the fifth metatarsal head, and the calcaneus, which are the major points that contact the ground. And just like a tripod, if you have shortening or malalignment of one leg of the tripod, you are going to alter the loading and position of in this case, the foot. And so this is kind of a key principle to understanding what happens with Lisfranc and other midfoot type of injuries. So a really classic example of this is a cuboid fracture. So a cuboid fracture can lead to shortening of the lateral column of the foot, sort of like shortening that leg of the tripod, and that leads to peritalar subluxation and uncovering of the talar-navicular joint because of the shortening of that column. And clinically, we see that as a flat foot. So we go from the first image, which is well-aligned foot, to a flat foot, which we see on the right side. And that's because of that relative shortening of the lateral column. And these are the deformities that in many ways that we're trying to prevent in treating a lot of Lisfranc injuries. So whether it's a cuboid fracture with shortening or subluxation of the tarsal-metatarsal joints laterally or whatever it is, we're really trying to prevent this sort of pes planus foot and all the issues that come with that in terms of the loading of the foot, imbalance load bearing, and all those types of issues. So before we dive into radiographic evaluation of the Lisfranc, we'll just talk about radiographic evaluation of alignment, which I just think is a critical foundation. And so I look at it very simply. On every foot x-ray I look at, I outline the talus, and then I draw a line down it and see if it's in line with the first ray. If it's deviating more laterally, then it's a pes planus. If it's more medial, it tends to be a more cavus foot shape. It's the same on the lateral. It's sometimes called the Meary's line, but you can draw a line down the talus, and that line should be in line with the first ray. And in fact, if I'm being critical of my example here, there probably is should be a little break in this line. It looks like there's a little bit of navicular cuneiform arthritis and a little break there. But anyway, so the point of this is just that you can assess the alignment of the foot by drawing these two simple lines. It's just the way you would look at coronal alignment and sagittal alignment of a tibia fracture. This is how you can think about alignment of the foot, and this applies to Lisfranc injuries and midfoot injuries, and it can be very useful. So again, if this line were angled apex plantar, then you'd have a flat foot. If it was apex dorsal, you'd have a cavus foot or high arch foot. The other critical sort of biomechanics principle that's important to understand are the essential and non-essential joints of the foot. So this was described by Sig Hansen, one of the sort of godfathers of foot and ankle surgery, and he talked about these joints that are, if their motion is lost, there is a substantial loss of foot function. There are other joints that are non-essential that it turns out you can take away their motion, and there's so little motion there that it really has little impact on foot function. And this is really helpful because I think when you first start looking at the foot, it can be a little bit overwhelming because there are so many joints, so many bones, and where do you even begin to develop a treatment strategy for this? But if you start just thinking about only the essential joints as being the ones that move, and view the other joints as just sort of these, almost all just blocked together as one bone, except for in cases of injury, then it becomes a little bit more straightforward. So the essential joints that you would not want to fuse or put fixation across are the ankle joint, the subtalar joint, the talonavicular joint, and the lesser MTP joints. The calcaneocuboid joint kind of gets put in a in-between category, and the lateral fourth and fifth tarsal-metatarsal joints as well. The non-essential joints is everything else. So, in particular, relevant to Lisfranc injuries, the navicular cuneiform joints, the intercuneiform joints, the medial column, first through third tarsal-metatarsal joints, all of those joints are fairly rigid, have not a lot of motion. And so there is a lot less downside to putting more rigid fixation across those joints. By the same token, any motion at those joints is likely to be pathologic. Okay, so now we'll talk a little bit more specifically about the Lisfranc. So the Lisfranc ligament goes between the medial cuneiform and the base of the second metatarsal. It has a dorsal, an interosseous, and a plantar component to it. The plantar ligament turns out to be the the strongest. So truly unstable injuries involve tears to all three of these ligaments, but there are sort of partial ligament, like Lisfranc sprains that can not completely tear this plantar ligament. This is just looking at it from a different perspective, and it's part of the point is just to talk about what's unique about the base of the second metatarsal is that it has this ligament between the cuneiform and the base of the second. All the other metatarsals have an intermetatarsal ligament between the second, third, fourth, fifth. That's those transverse lines there. But the Lisfranc ligament is a unique to the second metatarsal. It forms this medial column, which the medial column of the Lisfranc of the tarsal-metatarsal joint is the first, second, and third tarsal-metatarsal joints. We consider this the stiff column. And then there is the lateral column, which is the fourth and fifth tarsal-metatarsal joints, which is the relatively mobile column. And again, if you think back to that tripod example, if you think about a foot trying to accommodate uneven ground, you sort of need a little bit of wiggle in the tripod, and that really comes from the lateral column of your foot. How does it get injured? The most common mechanism is indirectly. The classic it's a landing with body weight on a plantar flex foot, or sometimes another classic example is landing on a plantar flex foot, and then in football, another player falls on the heel, and there's this axial loading along the kind of columns of the foot, and that leads to the Lisfranc injury. The direct mechanism is literally just a crush injury to the foot. Somebody drops something heavy on their foot, which is less common, but also something that we can see, but tends to result in some higher energy, more dramatic injuries. For the radiographic evaluation, we will go systematically through. We generally use the AP, the oblique, and the lateral view of the foot. On the AP view, you should assess all of the tarsal-metatarsal joints. You should assess really all the joints of the foot. But if you're going to really remember one thing, you should look at, make sure that the second ray is in line with the medial aspect of the middle cuneiform. That relationship should be preserved. What you see here in this injury on the right is a clear disruption between those two lines, and that's an indicator of a Lisfranc joint injury. So we spend a lot of time with Lisfrancs looking at that particular relationship. On the oblique view, because the foot is a Roman arch, The AP tends to show us the medial column, and the oblique, which is more orthogonal to the lateral column of the foot, shows us the lateral column. So in this one, we again assess all the joints and all the relationships. But the one that is, if you were to remember one thing, it would be that the fourth ray should be in line with the cuboid. And you compare that to this image of a really high energy Lisfranc, and you see that while there is a metatarsal in line with the cuboid, it's actually the third metatarsal. So this is a completely dislocated lateral column. On the lateral view, you want to ensure there's no dorsal subluxation. So you see in the top image, you can draw a line across the top of a foot. There's no break in that line, whereas in the bottom image, there is clearly the metatarsal is a little bit more dorsal than the cuneiform, and that's dorsal subluxation. And that's an indicator of a very severe Lisfranc. The low energy Lisfrancs, you won't see this, but in high energy Lisfrancs, you'll see this dorsal subluxation. Worth noting that when you're looking at a lateral view, if you're confused about which metatarsal you're looking at, just remember on the AP, the second metatarsal is the one that is more recessed. So we know that the one we're looking at here on this x-ray is the second metatarsal that's more dorsally displaced because it's recessed and a little bit more proximal than the other joints. So, a really reliable classification system for Lisfranc injuries has been a bit elusive. The Meyerson classification is the one that gets most commonly referenced, I think. But it's not one of those classifications that has a lot of clinical utility. Most people aren't saying, hey, I've got a tight B2, lateral dislocation Lisfranc. It's just not really something that you'll hear. But I do think it's still a worthwhile to sort of take in this image, and what it really, I think, illustrates is that there are a variety of patterns of how these midfoot ligaments can tear. I think we often think about it as more the sort of the type A, the top left one there, where the whole midfoot is just getting swept laterally, but it turns out there are a lot of variations. There can be divergence between the first and second ray, and you can get instabilities that also extend up into the cuneiform and intercuneiform joints as well. What I find most useful is to think about them just as a spectrum of injury, and that's really what drives a lot of the treatment decision making. So you have injuries like this one on the bottom left, where it's completely non-displaced, but maybe there are some physical exam findings that are concerning, and you're just trying to decide if there's an injury. You have the displaced injuries where you have a Lisfranc injury, but it's not so severe. And then you've got the completely dislocated, high energy, crushed foot situation, like the image at the far right. And the controversies are different for each. Again, you can characterize it a lot by just the degree of subluxation between that line that we draw between the middle cuneiform and the base of 2. With increasing degrees of displacement, we get different issues. So with no displacement, the question often is this a stable or unstable? Is this a subtle Lisfranc injury, or is there no injury at all? As you move up into the ones that are clearly displaced, there's no controversy about diagnosis, but there is controversy about how to definitively treat it. Should we do an ORIF? Should we do a fusion? So we'll talk a bit more about that. And then in the really high energy ones, I think the controversy or the clinical dilemma tends more to center around, is this something I should do all in one sitting, or they can sit in a splint, or do I need to do something emergently in the middle of the night to get this thing in the ballpark and then come back and do the definitive surgery at a later date? So essentially a 2-stage approach, like what we would take for a pilon or a bicondylar or tibial plateau. So we'll start at the kind of the lower energy end of the spectrum, which is diagnosing those subtle cases. So usually the tip-off for being worried about a Lisfranc injury is the physical exam, and it's often this ecchymosis on the plantar aspect of the foot is sort of pathognomonic for a Lisfranc injury, and is a Lisfranc until proven otherwise. There are sometimes this probably will not be present when you're seeing the patient in the ER the first 24 hours after injury, but by the time they come to see you in clinic, a week later, this usually will be present in a lot of Lisfranc injuries. The other little clues that might tip you off would just be swelling and tenderness in the midfoot. Again, non-specific, but those are things that you would look for. Metatarsal neck fractures or any other fractures in the midfoot area. Those are all the kind of things that will kind of set you down this pathway of saying, okay, I've got to make sure I'm not dealing with a Lisfranc injury. You'd rather kind of do the extra testing and make sure than miss one. So we begin a physical exam. Then we usually get the non-weight bearing x-ray. And again, sort of part of what defines a subtle Lisfranc is that it's not obvious on a non-weight bearing view. But then we can do stress either with, and my preference usually is just to use weight bearing. So you get a weight bearing image. Again, usually not in the ER because the patient's too painful, but usually when they come back later. If you're still unsure, you've got stress imaging, so you can do this either with or without anesthesia. You can apply a lateral force on the foot and see if you can reveal some instability, or you can use advanced imaging such as CT or MRI. So we'll talk a little bit about those, but I think I use the first three options there to diagnose and treat the vast majority of patients. So you have a suspected Lisfranc injury, whether from physical exam or whatever else. You start out, you get your typical foot x-rays. If it's displaced, you're done. You know that this is one that's going to likely need surgery, barring some strange contraindication. If it's not displaced though, and you're still suspicious, then that's when I would get the bilateral weight bearing x-rays. The bilateral is nice because it can just help you pick up on subtle differences at that base of the second metatarsal, just sort of the principle of asymmetry. So if on a weight bearing view you get dynamic displacement, then those patients generally would recommend surgery. And if not, then conservative treatment. Now the critical part here is, can the patient tolerate the weight bearing and all that kind of thing? If you really can, if you can't get the weight bearing x-rays to work, then you can consider advanced imaging or doing the stress examination, or sort of your other options. So the MRI, if there's really no fracture, it's probably going to be your next test of choice. It's got probably the best sensitivity. It is a little bit, they're not that obvious unless you're really good at reading foot MRIs. And so you want to have a good musculoskeletal radiologist who's going to be, reading it to help you make the diagnosis and decide on surgery or not. If you don't have access, I have somebody who's a good musculoskeletal radiologist, then I don't think the MRI is nearly as sensitive or specific. CT scanning is nice. It's just a little easier, practical to usually get them. The findings are simple, that any orthopedic surgeon could see the fractures that are present. But it's only going to get fractures. And you're only going to see subluxations that are present without stress. So it's not going to be as sensitive for those injuries that have no displacement without load. But I use CT a lot. If I see anything on the x-rays that suggests there might be fracture, then I'm more likely to go down the CT route. So it does have a lot of advantages for characterizing the bony injury, easier to read, easier to obtain than MRI, but it's just not quite as sensitive as an MRI with a really good musculoskeletal radiologist. The instabilities, if you do go the stress examination, or for whatever reason the patient's under anesthesia for something else and you want to stress the Lisfranc, then typically the way you do it is you can assess that base of second there, but you're going to do it by applying what I'm showing with the blue arrow here. Is you're basically going to grasp the forefoot and apply a laterally based force and see if you get any subluxation there, which you can see here. You can also see subluxation of the first tarsal metatarsal joint as well. So you can look at both. There is a longitudinal instability that's described as well. That's more instability that's extending up into the intercuneiform joint, if you kind of remember that Meyerson classification. So this would be revealed often just by a more AD duction force, but this is much less common, but just something else to be looking at and aware of. This is just a little video. See if this works. This just shows intraoperatively an assessment of This is a longitudinal instability. This patient also had the more transverse, the more typical instability at the base of the second metatarsal. But I guess my point in showing the video is that, you know, we use our x-rays, our weight-bearing x-rays to make the diagnosis of instability, but then you still intraoperatively are needing to assess, you should assess each of these different joints and stress them intraoperatively to decide what you need to stabilize, because sometimes it's much more extensive than what you initially realize. So this one was one that clearly had an instability at the base of the second metatarsal, but there was also this instability extending up into the intercuneiform joint. So that's the medial cuneiform moving next to the middle cuneiform. And so that intercuneiform joint also has to be stabilized. So in terms of the ER management now, as we shift up the spectrum and get into the more complex high energy fractures and dislocations, like any other bone in the body, well, not any other bone in the body, but you can get open injuries. So open fractures have to be treated emergently with surgical debridement and antibiotics. You can get compartment syndrome of the foot. It's a controversial area. I'm not really going to go deep into it on this talk, but it is a real entity. It leads to a lot of intrinsic muscle death in the foot, which can cause, you know, clawing and neuropathic pain and a lot of issues. So if there's compartment syndrome, generally speaking, you know, you want to release it. However, it's just not as easy to diagnose as like a tibia fracture compartment syndrome, because you can't, you don't have the same neural exam and all the different signs that you use to assess the tibia compartment syndrome are a little harder to do on the foot. But if you have a patient who's just in pain, really disproportionate pain, ton of swelling, you know, burning type pain, then you can you probably ought to release their foot compartments. What I'll talk a little bit more is about dislocation. So, you know, that's kind of one of my key messages, is that if you see a dislocated tarsal metatarsal joints, then that ought to be treated fairly emergently. The dorsal subluxation, I think, is sort of one of the big clues. If you see that dorsal subluxation, then you really ought to be trying to do some form of closed reduction. Often that can be done just by hanging the patient by the toes. You can sometimes apply a force on the dorsum of the foot to sort of push the tarsometatarsal joints back into place. But that can take it from being in a middle of the night surgical emergency to, you know, get it close reduce and then do a more, do the operative portion of it at a later date. If you can't get it with a closed reduction, then you've got to deal with it in the operating room. You've got, you know, some different tools at your disposal. You can do percutaneous techniques by inserting like a shoulder hook or similar instrument through little percutaneous incisions. You can use external fixator shank spins to manipulate, and then to actually stabilize it once you get it reduced. Then you can use K-wires is actually my preference for most length stable Lisfranc injuries. And then if it's length unstable, meaning one of the columns, just sort of like a bicondylar plateau, if you have a navicular crush or a cuboid crush that makes one of the columns unstable, then I really think the external fixator becomes really, really important, because the K-wires won't hold the length on it. But if it's just a pure ligamentous dislocation, then you would want to get it reduced. And then I usually just use K-wires. You can put K-wires in from medial and lateral just to hold it in place. And I think that's just a little less finicky than dealing with the X-fix sometimes. The other, I think, key message in talking about the kind of these difficult high energy ones in that initial surgery is you just want to make sure that you, if you do make a lot of little pokes or percutaneous things, that you're being mindful of where your definitive incisions are going to be. So I usually draw out the definitive incisions, and then if I'm going to put the shoulder hook or some other instrument in to manipulate, I'll try to do it, you know, in line with those incisions so that I don't cause myself headaches down the road. So where are those incisions for the definitive treatment? You know, the kind of standard dorsal medial incision is made I usually make it right over the EHL tendon, which is often palpable, but it's sort of in the interspace between the first and second metatarsals. You have to be aware that the neurovascular bundle is lurking there as well, and so you usually want to come down just medial to it. And then the lateral incision is generally made in line with the fourth ray, but you can modulate it to some extent depending on what you're trying to see, or localize with C-arm if you want to see more of the third or more of the fourth and fifth. The anatomy to be aware of is that you've got your extrinsic tendons going to the toes, and then you've got the intrinsic tendons that are coming from a more lateral origin on the calcaneus and sort of coming across. Like I said, for that medial incision, I usually just go through the EHL tendon sheath, which is the most medial tendon there. That's a pretty safe way to do it. Keeps you out of the neurovascular bundle, and then you can elevate underneath. For the lateral incision, again, you can modulate that to some extent. You're generally just going to work in intervals between the extensor tendons. You also do have to watch out a little bit on those for cutaneous nerve branches. On this right image, I think the thing that it's showing that you want to really be aware of is that the dorsalis pedis artery is coming down, and it dives down in between the first and second ray. So as you make that medial incision medial to the artery, and then you start elevating underneath it, you just have to be really careful that if you're extending that dissection distally that onto the base of the second, that you don't sort of cut across this branch that's diving down to the deep plantar arch of the foot. This is what the exposure sort of looks like from the medial incision. So you can see that it gives you this is the medial cuneiform here. The freer is in the inner cuneiform between the medial and the middle cuneiform. And then you see the first and second metatarsal bases. So right in the center where this gap is, that's the Lisfranc joint. And so what this image is really showing is sort of the cornerstone, so to speak, of the reduction. So you really have to, all this should have there should be no gaps between any of these areas. And this little corner between the second and the middle and medial cuneiform should be completely tucked in. What you can't see very well from this incision is really the third, TMT joint. So a lot of times when you pull the second over, you bring the third with it. But if you can't see it, then you have two options. One is you can make another window on the other side of the neurovascular bundle through the same incision, which isn't super soft tissue friendly, but will get you to the third. Or if you need to see the fourth and fifth anyway, then you can just make that lateral approach. And that usually you can see the third centered over the fourth, and then see the third and part of the fifth through that incision. In terms of the fixation, I think the key message is that your medial column should be fixed rigidly, and your lateral column should be fixed with temporary fixation of some kind. So, and that has to do with, remember, the essential and non-essential joints. The medial column it can be treated with flexible fixation. I'm sorry, I spoke. The medial column doesn't move, and so we can use rigid fixation. The lateral column has a lot of motion, and so we don't want to lock it up forever. So typically, I'm used for the majority of Lisfranc, just use screws. They can be solid or cannulated screws, just surgeon preference. And they have to address all the instabilities in the foot. I typically try to make sure that I've got at least 2 points of fixation across all the major instabilities, just because one screw alone, there can be some rotation. Plates, a lot of people are really into plates. The upside of plates is that you're not putting this hole, this 3.5 millimeter hole across the articular surface. But the problem with plates are that, in my opinion, in the first ray, plates are really kind of a little bit subcutaneous, and sometimes people feel them and they're not very well tolerated. To plate the second ray, you really have to do a much more exposure, because you have to make that exposure on the other side of the neurovascular bundle and kind of mobilize the neurovascular bundle just to get the exposure. So it's a lot less, soft tissue friendly I think, than doing the more the screws, but um, it does provide some definite advantages if you have a situation where you have a really comminuted second metatarsal base, because if it's really, really comminuted at the base, then the screws probably won't work. So those are the ones where I would think about much more about using plates. So for me, it's usually not for the first metatarsal. I'll almost always do screws, but I'll think about plates if the second metatarsal is too comminuted to accommodate screw fixation. And then the lateral column either gets no fixation if it's well aligned. If I reduce the medial column, the lateral column's perfect, and I didn't have to do any manipulation to achieve a lateral column reduction, then I usually don't fix it. If I do the medial column and the lateral column requires actually making an open incision and manipulating the lateral column in order to achieve a reduction, then I will maintain that reduction with K-wires, and the K-wires come out at 6 weeks so that the motion can resume. One of the bigger controversies in these Lisfranc injuries, the ligamentous injuries, are fusion or open reduction internal fixation. And when we're talking about fusion, I think it's really important, just backing up a slide. This is actually a fusion case. You fuse the medial column only, not the lateral column. So the lateral column fixation and treatment is exactly the same whether or not you do fusion. It's really what you're doing with the medial column. Are you just lining up the joints again, reducing the joints with the cartilage in place, and then putting screws in to hold it there and allow the ligaments to scar in and achieve almost like a scar fusion? Or are you, taking all the cartilage out, preparing the joints and stabilizing them with rigid fixation, trying to get bony healing? So because the outcomes of ORIF or ligamentous Lisfrancs haven't always been predictable, there has been some enthusiasm about doing primary fusion as your initial procedure. There's a sort of the classic article for this is a Lee and Coetzee article in JBJS. It's a small randomized trial. Only like 20 patients per group. They all had purely ligamentous injuries. But they found that the fusion patients had higher foot and ankle scores and higher function, and they had less reoperations as well. So this article really got people thinking a lot more about doing fusions. There's also an article from the group in Michigan where they had a little bit more mixed group in terms of the injury patterns, but in theirs they didn't see the same difference, but there were a lot of flaws sort of in the design of the study. They sort of used a pseudo randomization technique. They had a lot of bony Lisfrancs mixed in. But they did show a similar finding to the other RCT in that there was a lot more hardware removal. So for sure, you get like a really durable, sort of more durable result, less need for hardware removal if you do a fusion. So why does it make sense? Well, first you're, treating the post-traumatic arthritis before it even starts. So you don't have that issue of persistent pain that might relate to cartilage damage from the injury. You don't have to take any hardware out. A lot of patients with an ORIF, either you electively choose to take the hardware out or the patient has persistent symptoms and you end up taking it out later. But there's a lot less need for hardware removal with fusion because it's just a solid block of bone and the screws can just stay. It also, you don't get the secondary surgeries for fusion for the post-traumatic arthritis. And then of course the third thing is just that they don't have as much late deformity because you've got, you rigidly align them on the medial column. And so they shouldn't get late collapse through their Lisfranc, say after hardware removal. But why not? Okay, so sounds great. Why not just fuse everybody? Well, there is some downside. I mean, it does take time to prepare the joints. So there's an added surgical time, and with added surgical time potentially comes some higher risk. You are taking away motion. So there is sort of an argument for ORIF that, well, if I put the hardware in and then I take it out really early, especially in athletes or something, then maybe I'll preserve this normal foot motion because there are a few degrees of motion at these joints, and that'll prevent adjacent joint arthritis and all the other things we see with fusions. I think this is a pretty, you know, soft argument because there's really not much motion at these joints. And like we said, they're non-essential. I think probably the bigger issue is there are some technical issues with fusion. This picture, what it's showing is that the tarsal-metatarsal joint is about 3 centimeters deep. So it's a very deep joint, and you're usually coming at it from dorsally. So it's very easy to take the cartilage out and do really good joint preparation dorsally, but not plantarly. And what happens is when you close it down, that leads to a dorsiflexion of the first ray. And remember back to the tripod analogy, if we dorsiflex the first ray, what's going to happen? The camera is going to, fall over to the side, and we're going to get a flat foot. So, and you've just fused them in basically a flat-footed position. So you really don't want to do a dorsiflexion by union. So if you're going to do fusions, I guess the what I'm getting at is that you should be somebody who does like foot and ankle surgery somewhat regularly and knows how to do a good fusion, because you don't want to screw it up. The last thing is that the bone healing is probably more reliable than ligament healing, but you can still get non-unions with fusions as well. So you just have to watch out for that also. A quick note about delayed presentations. So what happens when people come in late? It doesn't happen that often in the United States, but they still get, missed occasionally. This was a kind of a nice study. They had 22 patients that came in early, and then 22 who presented late. And what they found was that the patients treated early with ORIF were better off than the ones presenting late who got fusion. Although the ones that got fusion did improve. So the take-home point was that if you get a late presentation, you can salvage it with a fusion, and that's a good indication for fusion, but you'd much rather just identify and treat them early. So that's kind of the key message there. You don't want to miss the diagnosis, you want to treat it. So, the relative indications then for fusion really are the purely ligamentous injuries, particularly the ones that are a little bit higher energy, with more significant displacement. So not the, athlete who was playing sports and got a Lisfranc, but the higher energy ones. And then delayed presentation. So patients who come in late, I just don't think you can get as reliable ligamentous healing. And so you're much more likely to go right to fusion in that situation. So that's all I have. So the take-home points, remember the key x-ray findings on the AP and the oblique and the lateral. And on the AP in particular, it's that relationship between the base of the second metatarsal and the medial cuneiform. That's the most sensitive place to look to diagnose a Lisfranc injury. And know that there is a broad spectrum of injury. At the one end of the spectrum, you just have to have a really high index of suspicion and identify and treat the subtle injuries. And at the high end of the spectrum, you have to remember that you may have to stage treatment, and that the dislocation is a surgical emergency, or at least needs to be emergently reduced. Remember that for the ones that do need surgery, you should fix the medial column with rigid fixation and the lateral column with temporary or more flexible fixation that can be removed to allow some motion to return to those lateral tarsal-metatarsal joints. And then lastly, there's pretty good evidence that fusion has some real benefits, particularly for purely ligamentous, high-energy Lisfrancs, and those that are present delayed greater than 6 weeks after injury. Thanks.